So molecular testing in addition is required. There are some essential biomarkers which should be tested, especially in the advanced stage lung cancer like EGFR, ALK, ROS. But at the same time, with the advent of immunotherapy, even the PDL1 or the biomarkers for the immunotherapy also need to be tested. So as we know that there are multiple biomarkers are available, but at the same time there are a lot of techniques are also available through which we can test them. So earlier everything used to be done in the molecular lab, but now there are some FDA approved companion diagnostics which are ISC based and can be used in the routine histopath lab. So these are some recommendations for testing of the biomarker testing, and which strongly recommend for an ALK and ROS in all advanced stage non-small cell lung cancer, especially adenocarcinoma. But even if the histology is other than adenocarcinoma, and if especially the patient is young, non-smoker, in those situations these tests can be done. If you are trying to look for the targets beyond ALK, EGFR, and testing by NGS is recommended. And with the advancement of the technology, now these platforms are quite sensitive to even pick up the EGFR up to the sensitivity of 20%. So earlier the cutoff for the method was 50%, which has reduced to 20%, and ALK is now recommended for testing for. But for ROS, if any case comes positive, it need to be confirmed by another method. Further, there is a need to which sample to be tested. Earlier recommendations were only for the tissue, but now any tissue or cytology specimen or even the blood, any material can be used, because this was possible due to the advancement of the technology. And now, not only that, we have to test for the acquired resistance, because many progress on the first line of TKIs, and those are to be tested. So but when we look into the actual biomarker testing, there are major challenges which we face is about the acquisition of the sample. So if a radiologist, if they don't give us a good representative samples, then we are stuck. So so your role in biomarker testing as a radiologist is very crucial, because it is not only for the diagnosis, but lot many tests are required, which will be possible only if you give us a good core. And if a radiologist send a sample which has only 1 or 2 core, it is just a wastage of procedure in the current era. So there are another challenges also, but we have to keep in mind that any samples from the lung can be used if properly planning is done upfront. So if you ask me if there is cytology sample, can you do it? So if the answer is yes, we can do it, but upfront at the time of collection, if you collect that material properly, then only you will be able to do. Which are used for the tissue cannot be applied directly on the cytology unless until you validate on them. So just to give you an example, there is a core biopsy which has very little tissue, but at the same time there is made from the smear. So these cell block and the cytology smears are much more useful to perform these molecular tests, rather than relying completely on the biopsy sample. So this is what we routinely do in all our reports. Now we mention about the tumor content of the tissue, so that even in the clinician sitting in the OPD, they come to know whether to repeat the biopsy or the procedures if there is a tissue which has a less amount of representative material. And it is also recommended we divide the tissues into the block which has less tissue, use it for the routine histopath diagnosis, and the more tissue is pushed for the molecular lab. And these are just summary of various tests which are routinely done in lung, and the tissue requirements also. So there are various requirements depending on which method you are using. And if you say and there are various like there some tests are RT-PCR based or NGS based tests, so they need relatively less amount of the tissue, but the planning for which test to be done need to be taken care upfront. So just to run through the journey, we have started biomarker testing in TMH way back in almost 2010. It's a and every year we keep on adding new tests and new technology into the armamentarium. But if you see the scenario in other centers, there is a slow adoption towards the biomarker testing. Just to give you the common occurring mutation alteration like EGFR, which is the one of the common alterations. But in EGFR, we must understand that it is not just a positive and negative. The type of mutations are also very relevant. Like there are mutation which are earlier presumed to be drug resistant, but with the new drugs, there are some mutations which can be targeted, and it also depends on the which platform, because there are many platforms which are available and some of them are FDA approved. But if your center is going for EGFR testing and selection of the platform, you have to very carefully look for the sensitivity and also see whether the same platform can be used for the blood, because that is a very important thing in the routine diagnosis. And this is the EGFR prevalence in Indian population. It is around 21 to 40%. And if you see geographical distribution based on our data, we see that in the patients who was from, especially from the North India, they have a low prevalence as compared to the patient from the north, either northeast or from the south. The ALK and ROS are the other next common alterations, and testing is done either by FISH or by ISC. And just to show the pictorial representation of example of ALK, so this is the break apart signals, means you are seeing separate yellow, green, right signals. That is a positive case. If such alterations are present in more than 15% of the case cells, it is a positive case. But doing FISH testing is little more cumbersome, and you need a fluorescent microscope, a lot of setup, and the alternative to that is ALK amplification by D5F3, which is FDA approved. It has relatively easy to perform, easy to interpret, and give us a very clear black and white answer. And based on our data, the prevalence for ALK was around 11%, and there is a very good concordance between ALK and IC and FISH. And we also observed there is a downward trend for testing for ALK by FISH, and at the same time, majority of the cases are now we screened by ALK. The ROS also, the earlier there was no clear recommendation, but it is now as per the current recommendation, it is one of the important biomarker, and whether to test by IC or FISH. So if you are using ISC, it can be used as screening, but any positive cases need to be reconfirmed by alternate methods. So that are the recommendation. And similar to the ALK, for the ROS also, testing by FISH is going down, but at the same time testing by immunohistochemistry is increasing. And the another method which is commonly used in the many labs is the PCR based method, but these we can't use for both ALK and ROS testing because they have many fusions. So unless until you have primers for all, you can't detect them. The other common alteration which beside ALK and ROS is the MET, and for this also there are various methods to pick, but recently most of the labs, they are testing it by using the NGS based method, because you don't have to test for the MET separately. So if we see these commonly occurring biomarkers, so even approximately 40 to 45% of the patients can be detected. So do we really need to use another modality which can give a solution in one shot? Yes, the NGS has made a very, very great hype, but it has a definite advantage of that, because the main thing is it give the solution at one go, but the pros, the cons are it is the technology is costly, it is not readily available, and it takes more time as compared to this single gene assays. So that's why if you are trying to look for the testing beyond EGFR, ALK and ROS, that is practically, and if especially if a patient if it progress in those scenarios, we have to go for NGS based testing, and then only it becomes more cost effective. So many labs are now are incorporating NGS in the routine diagnostic workflow, but these are the few key questions clinicians and keep on asking when we go for a NGS based testing. It is how frequently you test for it, and which panel if to be used, especially if the tissue is very limited. And in India now many labs have started offering a small gene panel. So are those sufficient or not? And if any lab takes more time to report on the NGS, is your clinician ready to wait for the results. So we have started NGS testing as a routine diagnosis in 2019, and we are using MySeq platform, and we tried. There are many labs which gives a very complicated report to which might not help. So the report should be as simplistic as so that it can be easily understood. And now more than approximately 350 to 400 cases we test by NGS every year. And lastly, if many of these patients do show the progression, so in those situations there are two solutions: either to go for rebiopsy or to do the liquid biopsy, because many new targeted second or third generation of TKIs are now available, and hence the role of a pathologist and molecular biology in management of lung cancer is evolving day by day. And lastly, to touch upon the response to the immune therapy, and these are the three commonly used biomarkers: PD-L1 by ISC, TMV or MSI. MSI is not being routinely done, especially in the lung cancer. And if a tumor shows a high PD-L1 expression, it is likely to show the high response to the immunotherapy. But it is also not a very robust biomarker for the immunotherapy. So towards the end, if you are doing all these modalities, if they are not discussed in the clinic and in a molecular tumor board, we are likely to either misinterpret this crucial information, and so hence there is a very crucial role of the molecular tumor board, which is also very uncommon practice in India. So after getting these complicated reports, these should be discussed in the clinic with both molecular biologists, pathologists, and the clinicians. So there is an increasing demand of these biomarkers, and we know that in our population some of these biomarkers are highly expressed, and in future ISC based biomarkers and NGS, they are the practical solution for the lung cancer management. With that, I conclude my talk, and if there are any questions, I will be happy to take them.
Thank you, Rajiv. Wonderful talk. I need to know whether I have to biopsy or not, because you are saying that liquid biopsy will take over. So what is the size in which liquid biopsy can be performed? So do you have any criteria on imaging, like, or the tumor volume in which the liquid biopsies can tell any specific results, whether there is a recurrence or not, or it doesn't matter, even if it is the smallest 1 centimeter or 5 millimeter size of the tumor, it can pick up on liquid biopsies?
So to this question, there is no definite answer on that, because if any on liquid biopsy, if anything come positive, it has a definite meaning. But if it is negative, then you think of all these possibilities. So there are other thing about the tumor biology, because sometimes based purely on the size, you can't predict the tumor biology. If it's really aggressive tumor biology, means it is a lung carcinoma with solid growth pattern, signature cells, micropapillary, which are likely to show early spread. So even if the size is small, they can be picked up on the liquid biopsy. But otherwise, there is no very hard and fast criteria. So what we do, try to do the molecular analysis based on the tissue. If it is not possible, then simultaneously go for the liquid biopsy.
Okay. So are there any comparative study between the two? And the second thing is that, can these liquid biopsies be used as a serological monitoring, so we can pick up the recurrence early, whether it can be feasible actually?
Yeah, so many people, it is being recommended, and there are some centers who are doing even serial monitoring using these liquid biopsies. So it is in work in progress, and some centers has really started adopting it in the clinical practice. So the thing is that as lung cancer is a very molecularly complex disease, and you never know if you are targeting for one molecule, like you target for the EGFR, there can be evolution of the or progression of the tumor due to another driver like ALK or any other new thing. So on liquid biopsy, you can test, if you do only limited testing like monitoring only for EGFR, then you can miss, and doing multiple time NGS might not be practically possible.
My question is to Naveen, whether you would, after treatment or after chemotherapy, you would like to do liquid biopsies, or you would like to do imaging?
I don't think they are both exclusive. We would always like to until we have robust evidence, we'll have to do both is what I would say. I don't think one can completely disregard imaging, at least the way it is. My, again, question to Rajiv is that you gave a very nice overview of evolution of how we started and where we are currently. So we have moved from invasive to more and more lesser invasive. But what is the spectrum heading towards? Are we going towards, what is the future looks like? Are we looking at some non-invasive tissue, like what is the role of urine cytology, or looking at ctDNAs in the urine, or what about breathalyzers? Do you foresee any future?
So 3-4 years back, especially if you're not very old, I also used to think that these things are all only in theoretical and not have a real clinical implication. But with the advancement of the technology, so the technology has played a very vital role. So the sensitivity of these platforms to pick up the mutations, so NGS based platform, they are sensitive to pick up even 1% or even less than 1% of the genetic alteration. So, and whether they are present in the blood or pleural fluid or even in the urine. So AIMS has done a study, which one of the theses I've reviewed recently. They have tested the EGFR testing on the urine, and it increases if you combine all three. So it increases the sensitivity, but practically how feasible is to do in the real clinic is a matter of debate. So can we use all three modalities considering the resources available to it? Yes. Yeah, so main thing is the technology is playing a great role, because the sensitivity to pick up these alterations, which was earlier not possible. And another thing, especially if you are using non-invasive techniques, so transport of the samples and sending it to the lab is also one of the important things, because when we started with our Varanasi center, used to send us blood samples, and at the end we used to get a lot of negative reports. So there are now specifically designed tubes, stylet tubes, in which if you send the sample, it preserves the DNA or the RNA integrity even up to the 3 days. So those transportation related issues can also be addressed. So that is also one important thing.
The primary sample from the lung, some genetic alterations are there, like, but from the lymph nodes they may not be there. Like, can you emphasis on that? So common is tumor heterogeneity, in terms of this kind of genetic alterations in lung. So
heterogeneity is well known, and it is acceptable, but based on the current guidelines, it is recommended not to target only the primary site. So whatsoever the easily accessible site for the biopsies, and it should be targeted. And as I said, sometimes it is impractical to compare on the both primary and the metastatic site. So any alterations positive. So in case if you have in the clinic doubt and everything coming negative, then you can look into that. But the decision for that based on the clinical judgment and the affordability. So, but practically it is not possible to test for at both primary as well as at the metastatic site. Yes. Yes. So repeat biopsies, even when we do at the baseline and we see completely a new mutation when it come at the repeat at the progression, or sometimes even at the distant location. So that heterogeneity can't be excluded.
Thank you. No, thank you, Rajiv. Thank you so much.
Thank you.